It's your turn.
Shall we start?
I
थोड़ा
think
सा
yes.
नेटवर्क इश्यू है लेकिन 11:33 हो गए हैं तो शुरू करते हैं
Yes,
सर.
you should start, and there is
Yes.
no network problem from our side.
हाँ,
You can
हाँ.
continue.
Okay, okay. Good morning, all. Myself, Dr. Neerav Unadkat, Associate Professor, Noble Ayurved College and Research Institute. It is my great honor and pleasure to welcome you all in webinar entitled with Systemic Approach, Hypertension, Modern and Ayurved Perspectives. On behalf of Noble Ayurved College, I welcome you all in webinars. Without wasting time, I introduced our chief guest, Dr. Subhash Waghe sir, Professor and HOD, Nidan Department, Sardar Patel Ayurvedic Medical College, Balkat. Uh, Hello, sir. Sir completed his UG from the Government Ayurved College, Nagpur. Also completed PG from the Sri Ayurved College, Nagpur, and PhD scholar at the MUHS. Besides this, he has 10 other degrees and diplomas to his credits. Sir wrote 22 Ayurvedic books and also wrote 54 research articles in the various paper reviewed ISS and journals. Sir received 14 different awards also. Sir got Best Book of the Year award wisely from the Ranade Foundation, Pune. Sir received prestigious award with Yadavji Trikamji Granth Puraskar from the Ved Kandiwale Pratishthan, Pune. Sir also received Dhanvantri Award, Best Global Teacher Award, Best Researcher Award, and Best Academician Award also. Sir reviewed 8 Lost Samhita of the Ayurveda and was felicitated at the Latur by the Ayurveda Update group for the same. Sir recently received Best Book of the Year award from his book on the astrology on Ayurveda from the famous Ayurveda Patrika, Nasik. Sir presented many research papers in the various national and international conference. Sir twice got Best Paper award also. Sir was invited as a guest speaker to 54 different national and international seminars, webinars, and conference. Sir took lecture on the international delegates of the Brazil, Portugal, and Russia. Presently, Sir is the president of the RVPGA organization and life member of the many other organization. Sir is an editor in the chief of IDGRA journal. He is on edited board of the many papers reviewed as ISS and journal. Sir is the editor in the chief of RVPGA international publications. सर हम भी आपकी बुक यूज करते हैं इधर ठीक है नाउ आई रिक्वेस्टेड टू डॉक्टर सुभाष सर टू स्टार्ट हिज सेशन थैंक यू सर
Thank you very much, Dr. Neerav, for precisely introducing me, although your voice was breaking a lot, and I hope many of us couldn't hear it properly. It was too lengthy. The topic chosen for today's presentation is hypertension, modern and Ayurvedic perspective. Why this topic is important? Because almost 1/3 of the Indian urban population and 1/4 of the Indian rural population is suffering from systemic hypertension, and it is the one of the cause of premature deaths. Secondly, 20% of the coronary artery diseases, it is because of systemic hypertension, and 30% of the strokes, they can be attributed to the systemic hypertension. So it is very important to go through the details of the systemic hypertension. So what we will see today in this particular presentation is the magnitude of the problem, definition of the problem, then the causes and its effects on three major organs: heart, kidney, and brain, its features, its management. And then after that is the Ayurvedic perspective. First, we will see the modern perspective, then we will go through the Ayurvedic perspective. So accordingly, I will share my PPTs. So is my screen visible to all? Is my screen visible?
Yes, sir, it is visible.
Yes, sir.
Shall I make a slideshow option so that you can watch it incomplete? Now it's okay. So magnitude of the problem as per WHO, an estimated 1.28 billion adults aged between 30 to 79 years worldwide have hypertension, and 2/3 of them are living in low and middle income countries like us. 46% of them are totally unaware of it. Less than 40% are diagnosed and treated. Most of them are accidentally diagnosed. The incidence of hypertension has doubled over past 2 decades, uh, maybe because of the better diagnostic things. 26% of world population is suffering from HTN. About 1/3 of the urban population and 1/4 of the rural Indian population have hypertension, highest being in the Northeast region. In 2017, Government of India launched the India Hypertension Control Initiative to improve access to treatment and control of hypertension. Now you will find that in the PSCs, they distribute tablets for the hypertension, which was not the case earlier. So what is blood pressure? The pressure produced when the left ventricle contracts and ejects blood into the aorta, which is called as a systemic blood pressure, in adults is about 120 mmHg. The pressure in the arteries during relaxation of the heart is called as diastolic pressure, which is about 80 mmHg. The difference between systolic and diastolic pressure is the pulse pressure, and it is measured by sphygmomanometer. We know now there are many ambulatory devices also to measure it. So determinants of blood pressure are cardiac stroke volume. Greater is the stroke volume, greater is the pressure. Heart rate, peripheral resistance, greater is the resistance, greater will be the pressure. Blood volume, elasticity of blood vessels. If the elasticity is less, then again it will exert more pressure. With the hardening of the vessel walls, viscosity of the blood, again it will have to work harder to eject the blood. Barrow and chemoreceptors, which uh, which are sensitive to the blood pressure variations. So if you define hypertension, it is an abnormal elevation of arterial blood pressure due to increased systemic vascular resistance caused by arterial constriction. It may be classified as follows: mild hypertension, both. You see, there are differences in classification of New York Heart Association, British Heart Association, European Heart Association, Australian Heart Association. Whereas British Heart Association, Australian Heart Association, and European Heart Association gives the hypertension, uh, classify the hypertension like this. Mild hypertension, 140 by 90 mmHg to 150 by 100 mmHg. Moderate hypertension, which is also called as stage 2 hypertension, 160 by 100 mmHg to 170 by 100 mmHg. And severe hypertension, above 180 and by 120 mmHg, also called as malignant hypertension or stage 3 hypertension. New York Heart Association, in the mild hypertension, it has uh, shortened the level as 130 by 90. So if you see the etiopathogenesis, essential or primary hypertension, essential hypertension is also called as primary hypertension, and 95% of the cases it is the essential hypertension what we found, where there are no specific causes On the 5% of the patients, they suffer from the secondary hypertension, which wherein you can trace about the causes. So some of the predisposing factors are given, such as genetic factors, racial, familial, being type A personality, like what we Indians share. Environmental factors, obesity, high salt intake, alcohol. Uh, Obesity, high alcohol, these are also included in secondary factors also. Humoral factors in high amount of circulating catecholamines, adrenaline, noradrenaline, like activation of renin, angiotensin, aldosterone system. Activation of this system leads to the formation of angiotensin second, which is the potent vasoconstrictor. Secondary hypotension, where you can guess about, we can guess about the causes, and you can rule out them, you can diagnose them. Renal causes, for example, renal artery stenosis, polycystic kidney, glomerulonephritis, chronic pyelonephritis. So there is a definite relationship between the kidneys and the maintenance of the uh, blood pressure. It is proved in several studies, and in many of the studies they have found that there is a reduction in number of nephrons in such patients, although the cause is unknown. Cardiovascular causes, coarctation of the aorta, endocrinal disorders, pheochromocytoma, Cushing syndrome, hyperparathyroidism, acromegaly, alcohol, pregnancy, other causes such as raised ICT, sleep apnea, drugs such as corticosteroids, non-steroidal anti-inflammatory drugs, sympathomimetics such as salbutamol, oral contraceptives. They're all been attributed to the secondary causes of secondary hypertension. We will see in little detail. So kidney disease and hypertension, this is how, because of hypertension, there is diminished glomerular filtration rate, and because of that, this renin, angiotensin, aldosterone system gets activated, and then there is a vicious cycle of elevated blood pressure goes on. Here you can see in case of renal artery stenosis, reduced renal perfusion, activation of renin, angiotensin, aldosterone system, formation of angiotensin second, which leads to the sodium and water retention, sympathetic activation, and vasoconstriction with the uh, circulation of catecholamines in the blood circulation, coarctation of uh, aorta. You can see in this second picture, narrowing of the aorta, and again, and one has to eject the blood against this narrowing, causes increase in blood pressure. Pituitary gland, it secretes hormones which affects many of the organs, but particularly here in case of the context of hypertension, uh, it is the adrenal cortex which is stimulated, and after stimulation of this adrenal cortex, what we see is the secretion of catecholamines, epinephrine, norepinephrine, also called as adrenaline or noradrenaline, which are the potent vasoconstrictors, which acts on heart and muscles. And there is role of angiotensin aldosterone system. You see, secretion of renin from the kidneys causes secretion of angiotensin 1, which is converted to angiotensin second, which on one hand causes systemic vasoconstriction, on other hand stimulates aldosterone to retain the sodium and water. And again, the by secretion of ADH, antidiuretic hormone, sodium and water is retained. In case of Cushing syndrome, wherein there is an increased glucocorticoid, which raises the serum cortisol level and the adrenaline level, thereby increases the BP. So you see these patients are there. They are goal face wale, moon face it, and injection of corticosteroids can worsen the condition. Pheochromocytoma again causes the excess release of adrenaline and leads to the rise in blood pressure. So you can, if you have the associated features, for example, see this like stereo gravidarum, or these are lines on the abdomen and the flush on the face, and uh, on the extremities also. These, if there are this such markings with the associated features, we can guess about this, and after doing the uh, particular investigation, we can guess about the pheochromocytoma. Hyperparathyroidism. This can also cause a rise in hypertension with the increase in aldosterone level, and there is oxidative stress, inflammation, and fibrosis, which leads to the stiffening of the blood vessel, rising the blood pressure. Acromegaly, again, the role of GnRH and anterior pituitary, and the whole cascade is whole cascade adds to the rise in blood pressure. So if you see the pathophysiology, hypertension is an important risk factor for atherosclerosis and accelerates the disease, particularly in coronary, cerebral, and renal circulations. In the early stages, it is reversible, but in long-term, irreversible fibrinoid necrosis develops in arterial walls. So in cerebral circulations, uh, atherosclerosis and microaneurysms, uh, it may lead to the transient ischemic attacks or stroke also. In coronary artery disease, it may cause myocardial infarction. So mild hypertension is usually asymptomatic. Epistaxis and headaches are possible symptoms. In some cases, epistaxis is self-limited. Cause-specific features in secondary hypertension is noticed. For example, sweating and tachycardia in pheochromocytoma, angina in coronary artery disease, LVH and breathlessness in heart failure, transient ischemia attack like features in cerebral vascular disease, periorbital edema in renal diseases, retinal hemorrhage, and exudates producing blurring of vision. Uh, Actually, when you diagnose hypertension, you need to do the retinoscopy, which we're going to describe in subsequent slides also. Malignant hypertension can cause nausea, vomiting, severe headache, convulsions, visual impairment. Uh, you can get in toxemia pregnancy also, where there is a rise in blood pressure above 180 or 120. Transient ischemic attack and altered consciousness, symptoms of heart failure. Effect on organs. Because of systemic hypertension and increased vascular resistance, there is deterioration of left ventricular contractile function leading to there is LVH first, left ventricular hypertrophy, and later on there could be a decompensated heart failure also. So hypertension is the major risk factor for coronary artery disease in 20% of the cases. You see hemodynamic stress of chronic blood pressure produces a left LVH, left ventricular hypertrophy, and then the decompensated heart failure. In brain, accelerated atherosclerosis and microaneurysms causes cerebral edema predisposed to stroke by leading to cerebral infarction and cerebral hemorrhage. So there could be occlusion of many arteries. In 30% of the cases, the stroke occurs because of systemic hypertension. Kidneys, as I already told you, because of reduction of the perfusion, there is reduced GFR and reduced sodium water excretion. Reduction in renal perfusion activates the renin-angiotensin-aldosterone system, which produces ultimately the angiotensin second, which is the potent vasoconstrictor, and the aldosterone, which leads to sodium water retention. So these all adds to the rise in blood pressure. Proteinuria and hematuria may also occur, worsening the renal function and in turn increasing the hypertension. Particularly when it is co-associated with the diabetes, you need to check for the microproteinuria and accordingly start the treatment. So hypertension-related renal complication. First, there is a increased granularity of the uh, of the kidneys, and then there is endothelial damage, which ultimately leads to the end-stage kidney disease. So examination, as you do uh, with the sphygmomanometer or the ambulatory uh, measuring devices. Uh, while examining the heart, you can get the third heart sounds. There could be tachycardia. Uh, even there may be a atrial fibrillation if it is not controlled. Loud E2 may occur. A parasternal apical hue may occur. Retinal changes, grade 1 narrowing and increased tortuosity of the retinal arteries giving silver wire lining. Grade 2 apparent narrowing of the retinal veins, which we are going to see at the junction of arteriovenous crossing. Grade 3 vascular changes with the flame-shaped hemorrhages and soft cotton wool exudates. We will see how it looks. And the papilloedema. Bulging and blurring of the edges of the optic disc. One needs to get acquainted this procedure, and this should be the routine examination what we should carry out in the OPD. So you can see the silver wiring, cotton wool here, and the cotton wool spots this exudate these here, papilloedema, and these are the hard exudates. Here we will see one more. So grade 1 narrowing and increased tortuosity of the retinal arteries. Grade 2 apparent narrowing of the retinal veins at the here arteriovenous crossing. Here there is the narrowing. And grade 3 vascular changes with the flame-shaped hemorrhages and soft cotton wool exudates, which are actually seen in grade 4 slide. Bulging of the optic disc, papilloedema, and these are cotton wool-like exudates. So in investigations, if you take BP with the sphygmomanometer, X-ray chest, it may show the left ventricular hypertrophy, or if coarctation is the cause, then it may be evident. ECG may reveal left ventricular hypertrophy, myocardia, or ischemia, hypo or hypokalemia if the treatment is going on. Echocardiogram may show left ventricular hypertrophy. Fasting lipid profile may show increase in total and LDL cholesterol. Urine analysis may show proteinuria or glycosuria if diabetes coexists. Serum creatinine to assess the kidney function. Serum electrolytes, hypokalemic alkalosis may indicate primary or secondary hyperaldosteronism, or which diuretic therapy is the commonest cause. 24-hour urine analysis for vanillin mandelic acid on metanephrine excretion if pheochromocytoma is suspected. Intravenous urogram to rule out renal artery stenosis, and urinary cortisol estimation if Cushing syndrome is suspected, or whether whether if there are pituitary tumors also, you should suspect for the Cushing-like syndrome, and you should do the urinary cortisol. Complications which we have already seen, the treatment here. What I want to lament that first encourage the patients to adopt for the non-pharmacological measures, because once you start the treatment, patient may have to take it for lifelong, and they have their own complications. Most of the treatment which is offered for the control of hypertension, most antihypertensives, they are diabetogenic. They have the potential to induce diabetes. Uh, whatever the, although most of the people they blame the beta blockers, but all they have the potential to cause diabetes, and all the diuretics, they have the potential to cause diabetes. Non-pharmacological measures among this, the weight reduction, we must uh, encourage the patient to reduce the weight. Reduction in weight not only decreases the resistance to the insulin, but reduces the blood pressure also. So 30 minutes daily walking is what suggested. Salt restriction, not more than 3 to 5 gram in 24 hours. Reduction in alcohol consumption. regular exercise, meditation, and biofeedback, because we all are facing n number of stressors every time our body is in fight or flight mode, and that because of that there is constant increase in circulating catecholamines in response to fight and flight, and level of adrenaline and noradrenaline, they are increased. So it is very important to reduce the mental stress. And mental stress is not only causing the systemic hypertension, but it is also one of the major cause of diabetes mellitus in type 2 cases. Stop smoking. Smoke definitely smoke. Cessation of the smoking improves the control of the blood pressure. Tobacco is the culprit in all forms. Tobacco, wherein either resistance hypertension also, where you are not getting the results to the pharmacological therapy, you just ask the patient to stop the tobacco in all forms, whether it is smoking or manjan or whatever it is, or gutka, and you get the dramatic results. Modern drug therapy includes the therapeutic agents like diuretics, beta blockers, calcium antagonists, angiotensin converting enzyme inhibitors, ARBs, angiotensin receptor blockers. Choice of antihypertensives in older patients, combination of calcium antagonist and thiazide diuretic, amlodipine plus hydrochlorothiazide is what we notice most commonly. Patient with angina, tachycardia, beta blockers, metoprolol is the drug which is frequently prescribed. Patient with heart failure, AC inhibitors are the drug of choice, or ARBs also. Or what you notice are telmisartan, olmesartan, etc., and ramipril, etc. Patient with benign prostatic hypertension, alpha blockers we see. So among diuretics, diuretic therapy, there are loop diuretics, thiazide diuretics, potassium sparing diuretics, beta blockers, atenolol, metoprolol, propranolol. Loop diuretic causes hypokalemia. Thiazide actually doesn't causes that much hypokalemia, and it's a long-acting one. And so potassium, because of the loss of potassium, we sometimes institute potassium sparing diuretics like aldactons. Atenolol, metoprolol, propranolol, they were the drug of choice earlier, but now you see with the increasing evidence that they causes diabetes, or they exacerbate the diabetes in type 2 patients if they are receiving these antihypertensives. The role is now limited. Just some newer varieties like carvedilol, nebivolol, etc. They are uh, given considering their potential benefits in concomitant heart failure. Calcium antagonists, nifedipine, amlodipine, verapamine, diltiazem, AC inhibitors include captopril, lisinopril, enalapril, ARBs, famous, telmisartan, olmesartan, valsartan, etc. So diuretics, when we were the students, diuretics was the first line of treatment for controlling the blood pressure. Now, they are not, this is not the case now. They act by promoting the renal excretion of salt and water by blocking the tubular reabsorption of sodium and chloride. The resulting loss of fluid reduces the ventricular filling, that is preload, and produces consistent hemodynamic and symptomatic benefits, and rapidly relieves the peripheral edema and dyspnea. Although they are used in heart failure, what I already told, the problems about these loop diuretics and thiazide diuretics and potassium sparing diuretics, but all they are potentially diabetogenic and uh, should not be used rampantly, but cautiously. Venodilators, they reduce venous return and improves the preload. They increase the cardiac output by 18 to 25%. Oral nitrates, the isosorbide mononitrate, isoside dinitrate, sorbitate, which is very popular. And if you need some instant type of reduction in BP, this sublingual sorbitate is used. But if there is a CAD and if there is inferior wall MI, one should not use it. Patient may go in collapse. There are arterial vasodilators also. They reduce the afterload by reducing the peripheral vascular resistance. Prazosin by blocking the alpha-1 adrenergic receptors. And another one is hydrolysine. It produces large decrease in systemic arterial resistance, and thereby improves the cardiac output. It's given 25 mg per 6 hourly. Sodium nitroprusside 5. This is given actually when there is malignant hypertension and you need to reduce it. It is given in IV form, micro drip, uh, with a silver coating, because it can cause reaction with the sunlight, and it can give rise to the formation of sodium thiocyanate, which is very fatal. ACE inhibitors, they act by causing the inhibition of angiotensin converting enzyme, which prevent the formation of powerful vasoconstrictor, that is angiotensin second. It blocks it at that level and improves the survival of heart failure patients. Yeah, the popular drugs are captopril, lisinopril, enalapril, and ramipril. ARBs, they block angiotensin second receptors on the muscle surrounding the blood vessels. As a result of which blood vessel dilates and blood pressure is reduced. They reduce the blood pressure and makes it easier for the heart to pump the blood effectively and improve the heart failure. तो जो हमारे ब्लड वेसल के सराउंडिंग के ऊपर जो अलग अलग टाइप के बीटा रिसेप्टर्स, अल्फा रिसेप्टर्स और हर चीज के लिए रिसेप्टर्स लगे हुए हैं, जैसे एंजियोटेंसिन सेकंड के लिए भी रिसेप्टर्स है। एंजियोटेंसिन सेकंड जाने से पहले ये खुद ही जाके वहां बैठ जाते थे। दे ब्लॉक द एंट्री ऑफ एंजियोटेंसिन सेकंड इनटू द cells, so thereby causes the vasodilation and produces consistent hemodynamic benefit. Losartan, telmisartan, olmesartan, valsartan are the drugs in this group. Beta blockers, they were actually some 25 years back, they were the first line of therapy. But nowadays, they are kept on hold and given in specific conditions, as they not only because of their potential to cause diabetes, and they exacerbate if the patient is on already a case of type 2 diabetes, it increases the blood sugar. So has been traditionally contraindicated in patients with congestive heart failure and the bronchial asthma also, because they blocks the beta receptors, both beta 1, beta 2. Now they are the mainstay in treatment of congestive heart failure, as the only medication that shows substantial improvement in LV function, and multiple studies show improved survival. But this is limited to newer drug carvedilol and anebiolol. Now let us see the hypertension in Ayurveda. So, well, we do not find direct reference to the word hypertension in Ayurveda, but Rudrida Plavavegena, they were having, the ancient acharyas, they were having the idea that it is the blood which exerts the pressure on the arterial walls, and what they perceived through the pulse examination. And some of the authors, they tried to correlate with Sira Raktabhar, Sira Raktabhar Buddhi, Raktaveg Buddhi, Vyan Vikshepal, etc. But we will take what is important from the point of view of NADI examination. The commonly correlated Ayurvedic condition with hypertension is Siragat Vata, due to its features and due to its features. So as per Nadi Tantra, artery pulses due to the pressure of the blood in it. So this is the, they were having the idea that the blood is exerting the pressure on the arterial walls. Ancient acharyas have described the blood pressure variations in pulse in different mental states like anger, sexual arousal, worry, fear, etc. The causes of increase in blood pressure, where you get the decreased blood pressure, where you get the increased blood pressure. Ayurvedic acharyas are of the view that blood pressure in pulse rises in mental states like anger, sexual arousal, which increases the heart rate. Like in Kanad Nadi Vigyan, it is given, and it's very when you get angry, fight mode or sexual arousal, there is increase in circulating catecholamines, adrenaline, and it leads to the vasoconstriction and thereby increase in blood pressure. Increase in blood volume also increases the blood pressure. Actually, in the second slide, we have seen the determinants of blood pressure. The blood volume is one of the determinant. Greater is the blood volume, greater will be the pressure. Ayurveda, the condition of rasa vruddhi refers to the state of increase in blood volume characterized by features like increased salivation, nausea due to the increase in blood pressure. There are a number of dietary factors like consumption of extra salt, water, liquid preparation, which increases the blood volume. So where this blood volume gets increased, the overconsumption of liquid causes the pulse to be full and fast as it increases the blood volume. It is given in Nadi Tantra. As per Kanad, increased salt intake causes pulse to be fast due to increase in blood volume. And the ingestion of vegetables, banana, kadli phala causes pulse to be full in volume as per Kanada. Increased venous return to the heart also increases, resulting in the increased stroke volume and cardiac output. Increase in cardiac output leads to the increase in blood pressure. Now, where the blood pressure decreases, as per Kannada, blood pressure decreases in mental states like worry, lack of enthusiasm, fear, obviously, decrease in blood volume. Severe exercise leads to the dilatation of the blood vessels and thereby fall in blood pressure. This is obvious. And the Rasaksha conditions, where state of decrease in blood volume characterized by features like increased thirst, tachycardia, emptiness in heart, chest pain, etc. Due to decreased blood volume, the waves in the arteries cannot achieve the height and is referred as low volume pulse. Examples of low volume pulse, in diarrhea, the pulse is slow, cold. When the diarrhea is associated with vomiting, the pulse is not felt, or all due to severe blood fluid loss and result low blood volume. It is mentioned in Nadi Tantra. So hypovolemic pulse. In menorrhagia, that the pulse is slow and weak. Again, the cause of blood hypovolemia. So etiology of hypertension could be, as per Ayurveda, if you see the causes of rasavruddhi, excessive intake of fatty food, sugar, heavy food, alcohol, meat of animals, intake of cow milk, grounded wheat, lack of if you see the lifestyle factors, lack of exercise, day sleeping, sexual arousal, anger. These these are all the causes given of rasavruddhi. Pathogenesis of hypertension can be traced as per Ayurveda. The consumption of above stated fat-rich dietary factors and lack of exercise lead to increase in kapha and mutation of rasa, causing obesity and deposition of fatty layer in the blood vessels through the some lepa, what they have mentioned, leading to narrowing of vessel lumen and developing the features like edema. This can be traced in Charak Sutrasthana 23 and 28 also. The formation of ama due to overproduction of kapha and cessation of agni to digest it also leads to the obstruction of blood vessel. It is given in Ashtanga Hridaya Sutrasthan 13. The sexual arousal anger causes blood vessel narrowing. The narrowing of blood vessel due to deposition of fat leads to increase in blood pressure, resulting features like edema fit. So features of hypertension, what is mentioned in Ayurveda, Nadi Tantra book, increased pulse rate, insomnia, lack of interest, body ache, restless, and edema. The treatment, uh, non-drug therapy, as far as non-drug therapy is concerned, again, all the predisposing etiology should be avoided. And it is best mentioned in Charak plus Sushu Sutrasthana 15/32, Rasa Nimitta Sthaulya. So diet should consist of yava, barley, kordu, shama, uddalak, as these are the low-calorie foods. Avoidance of day sleeping, doing regular exercise, regular meditation, avoidance of tobacco smoking. And Yog Ratnakar is probably the first book which I mentioned the effects of the tobacco. And particularly, it had mentioned that it is the smoking of the tobacco which puts bad effect on the health of the heart. So tobacco was introduced in our country by the Portuguese in 14th or 15th century, and this is the 17th, late 16th or early 17th century book. Almost of the 100 years of introduction of tobacco in India, this Yog Ratnakar had alerted about the side effects of tobacco smoking. And this is probably the first documented evidence. Whereas in modern science, it is the famous Framingham study in 1960 to 62, which was carried out, uh, which highlighted the effect of tobacco smoking on the bad effect of tobacco smoking on the heart health. So in our book, it is mentioned far earlier. And another thing, what we must take into account before starting the pharmacological therapy, that if you are going to vasodilate, then there is a perfusion deficit, uh, uh, and there is a reduced blood supply to the exercising muscles, etc. So there could be muscle cramping, body the patient after instituting the pharmacological therapy, patient may don't ignore the complaints of the patient. Patient may complain that is noticing the weakness, muscle cramps, fatigue, jaldi thakaut aati hai. These are all due to the hypotensive effects of the pharmacological agents. You must pay attention. So what general practitioner do? He add one B complex or hematinic preparation and consoles the patient, but it is not like that. It is the manual. It is the hypotensive effect of the drug which is causing that those features. So in Ayurveda also, particularly Nadi Tantra book. So in 17th century or 16th or 17th century, these were evolved, and it is the again first documentary evidence that Sarpagandha was asked to give in the patients of hypertensive patients to lower the blood pressure. So they have mentioned it lowers the elevated blood pressure and also normalizes the heart rate. It is given in Nadi Tantra book. Classical Ayurvedic preparation available in market is Sarpagandha Veti, a whole root powder. In modern science, they have precipitated alkaloid. That tablet Reserpine was earlier there in far earlier. It was, and I think late 70s and early 80s, but now it has been banned because of its psychological effects. Reserpine lowers blood pressure by decreasing cardiac output, peripheral vascular resistance, heart rate, and renin secretion by depleting the circulating catecholamines. Ayurvedic beta blocker like action is noticed in Pushkar Mool. AC inhibitor like action is noticed in Mandukparni. Diuretics are Punarnava, Sachar, Parushka, Kasmarda, may be given in combination. Antihypertensive plus diuretics, uh, Vacha, Nimba, Punarnava, Sachar, these they exert the synergistic effects. Antihypertensive and antilipids. In this class, the Vijay Sar, Vijay ki Lakdi, what we commonly popularly called as, it's no, it's beyond doubt that it is having the anti-hyper glycemic effect. It an anti-hypertriglycemic effects also. It lowers the lipid and it lowers the sugar also, and it is established with many trials. The active principle pterostilbene from the wood produced as a fall in BP in anesthetized dog. Other ducks, Shankapushpi, Jatamansi, Lashuna, these allium sativa. Daily single piece of garlic helps to control the hypertension, prevents the thickening of heart and arteries. It is proved in many trials. Some of the uh, some Chinese drugs. One such drug is this lingastic, and the active principle tetramethyl pyrazine, which is found in this drug, which inhibits the platelet aggregation and lowers blood pressure by vasodilation by calcium channel antagonism. Another drug is Ancharia rhincophylla, uh, and the alkaloid is rhincophylline and hirsutin, which produces the vasodilatory effects. So these also hold the potential to lower the blood pressure. Another is Evodia, ruticarpa. Another is the Chinese herbal drug, which is used for the hypertension, and the active principle is ruticarpine. And they explore, Chinese people, they explore, and we somehow, we Indian fail to explore the potential of our herbs to lower the BPs and another thing, the other things also. There are some branded Ayurvedic drugs for hypertension. I'm not going to advertise anyone, the Bipasil or BP's logo sliding, uh, but how much they are effective, again, it is debatable. But in most of the preparation, the benefit is that they also act as lipid lowering agents and anti-anginas. So at what dose they produce the consistent hemodynamic benefit by lowering the blood pressure is again a matter of research. So thank you very much for your patient listening. If you have any questions, we can take those. Can you hear me? Dr. Nirav?
Yes, sir.
Yes, sir.
Okay. Please check the in the chat box whether there are any questions in it, or if students want to ask directly, they can ask.
Students, any questions? Please drop your question in the drop box.
I hope the audience, they got the fair enough idea of the hypertension and they can manage it better. Still, I would like to answer some of the questions if they have any.
Anyone who has questions could ask, sir.
There is one question: can we do the Rakta Mokshan? But it may help a little, but I don't think it will produce the consistent hemodynamic benefits. When they are hypercoagulable states like polycythemia, it may help a little. Please see if there are any questions. So it is always beneficial or advisable to ask the patient to adopt the non-pharmacological measures first before putting the patients on antihypertensives, because they have a lot many complications. Ask the patient to do regular exercise, to get de-addicted for tobacco smoking and alcoholism. Adopt a healthy lifestyle, do the regular meditation. It helps in controlling the BP, and consume more leafy vegetables like methi, etc. They have a effect like angiotensin converting enzyme like effect. So putting the patient and on pharmacological therapy is easy, but dealing with its the unwanted effect is, I mean, it's an art to counterweight the balance. And I think the elderly patients above 60, they are the ones who absolutely require the pharmacological therapy. And in younger population, as far as possible, try to or encourage them for the non-pharmacological measures, de-stress, to get de-stress first. If at all these measures fails, then you can start with the low dose, and depending upon the condition and the age and the other factors, contributing factors, you can alter the therapy.
In chat, role of bath in hypertension.
Love bath. I don't think it has, but it produces the positive feelings and prasannata, what causes, and prasannata leads to the normalization of many things.
Also, one question: which karma helpful to reduce the hypertension?
Which, sorry,
Panchkarma uh, helpful
which
to
one?
reduce the
Hypertension.
yes.
Okay. Well, what Acharya has suggested for all the control of diabetes and Shodhan therapy for everything. So ours is the pathology is Strotasam Lepa. To reduce the Strotasam Lepa, uh, the atherosclerotic effects, and for this purpose, both the Shodhan therapies, because of their Vyavai, Vikasi, and Sukshma Guna and Chedan property, both Vaman and Virechan, they should produce the beneficial effects. And after that, one can institute the regular therapy. So it will require a low dose to control. So if you have knowledge of Ayurvedic therapies and modern science also, you can best amalgamate those therapies, come to the midpoint, and what will be the best for your patient, you can decide. After doing the Shodhanas, probably your patient will require a low dose of the antihypertensive drugs.
Okay. Anyone question?
How to assess hypertension by doing Nadi Pariksha?
So, although it is not the standard procedure to ascertain the hypertension with the Nadi Pariksha, what we see by examining the Nadi is the pulse pressure, which is the systolic minus diastolic pressure is the what you get the pulse pressure indirectly. So Druta Nadi, etc., what the varieties they have mentioned, and the conditions like krodha, anger, sexual arousal during that Nadi, uh, what the acharyas have mentioned, that is the nadi for the hypertension. But it is not the gold standard. Gold standard is the sphygma with the sphygmomanometer. Patient in a sitting position, properly relaxed, and if on two or three different occasions, if the findings are consistent of it is above 140 by 90, then you can think of. But at for one sitting, where you should not confirm that it is hypertension, because many times patients are frightened with after when they see the white coat means the doctors, the BP gets increased. BP is a dynamic phenomena because it keeps on changing as per the situation, and we all are faced to the flight, and our body is kept on fight on flight mode every time, because many stressors they act. Sometimes we fear for the exam, sometimes there is a pressure to accomplish any task in the limited duration, and we kept on running. In this condition, the level of circulating catecholamines is raised, which causes vasoconstriction, and thereby increasing blood pressure. If this condition keeps for we are in stress for too long, then the BP is persistent. Otherwise, BP keeps on changing. So and even after starting the pharmacological therapy, you should keep the proper follow-up and see whether patient is maintaining the normal blood pressure. The stressor might have gone, and you may need to withdraw the drugs, but that should be withdrawn very cautiously, and long-term follow-up is needed.
Sir, one another question. Can we give Basti of the antihypertensive drugs?
Now, why we should choose that route when we have the proper route to give?
Thank you, Waghe sir. I think all questions are almost covered. Very good afternoon to everyone. I, Dr. Sania Rahman, Assistant Professor of Rog Nidan, Vikruti Vigyan Department, have been given this privilege to extend my vote of thanks for today's webinar. First of all, I would like to extend my gratitude to respected Dr. Subhash Waghe sir for taking out his time and giving us knowledge about this session. Sir is an esteemed personality in his uh, uh, innovative approach towards explaining the fundamentals of Rog Nidan and Vikruti Vigyan subject and has been applauded by all. His textbooks on Rog Nidan subject is being referred all over India. I myself have personally referred his book since my PG days from Government Ayurvedic College, Nagpur. Many concepts regarding hypertension have been cleared from today's webinar. Hypertension being Anukta Vyadi, the concepts needed to be explained, and it is well explained from today's session. Waghe sir explained from basics of hypertension, covering all relevant conditions related to hypertension. And his also modern concepts of treatment related to hypertension is well explained in today's session. So thank you, Dr. Subhash Waghe sir. I would extend my gratitude to Dr. Manoj Runghe sir, Dean and Medical Director of Noble Ayurved College and Research Institute, Junagadh, for arranging this thoughtful session for all of us. I would also like to thank all the professors, associate professors, assistant professors, as well as students of Noble Ayurved College and Research Institute for lending their precious time and attending today's session. Thank you.
Thank you everyone
Thank
for
you.
patient listening, and a special thank to Manoj Runghe sir for giving me this opportunity. Thank you very much, sir.
Okay, thank you, sir.
Shall we end the meeting?
Yes, sure.
The
Runghe
webinar
sir
is
is
now
there.
being concluded.
Okay. Please ask Runghe sir if you want to comment before closing. I think he's there.